Greetings everybody on behalf of Bombay Orthopaedic Society. Bombay Orthopaedic Society is one of the oldest societies in India, and WIROC is the annual conference of Bombay Orthopaedic Society. This is the 56th annual WIROC, which we have labeled as WIROC Global. We have invited societies across the globe to participate in WIROC Global, and we are glad to say that more than 70 societies are participating in the event. I'd really like to thank Spot for participating in WIROC Global on behalf of my president, Dr. Sangeet Gawale, and Dr. Vishal Kundnani, my co-organizing secretary, and the entire Bombay Orthopaedic Society Executive Council. I again welcome you and thank you for your participation in WIROC Global. With this, I'll hand it over to Dr. Torres, President of Spot. Over to you, sir. Dr. Torres, you can go ahead, sir.
Yeah, just one word by me. The Torres is a very good friend of mine, is orthopedic surgeon at British American Hospital and is currently the president of the Peruvian Orthopaedic Society and is also the vice president of the Latin American Arthroscopy Society and past president of the Peruvian Arthroscopy Society. Thank you very much for joining us, Dr. Torres. Over to Dr. Torres.
Thank you, Sasi. Thank you, Dr. Ashok. Good afternoon, dear friends. I'm David Torres, Orthopedic Peruvian Society's president. It's an honor for us to be part of the Congress, sharing knowledge and experiences from our work in our country. We extend an invitation for all of you to be part of our Orthopedic Congress. It's going to be this year on September in Lima, Peru. We are about 1,200 orthopedics in Peru. We are going to be very glad that you participate in our Congress. Thank you.
Thank you very much, Dr. Torres. So we will go ahead and proceed with our talks. First, we have a talk on complications in hip arthroplasty by Dr. Marcelo Lizarraga. Please forgive me for my pronunciation. Dr. Marcelo is Chief of Hip and Knee Unit at Military Hospital, Peru, Consultant Navy and Police Hospital, and past President of SPOT. He is also Director at San Bernardo Clinic and member of AOS, AHKS, and EHS. Welcome, Dr. Marcelo.
Can you hear me?
Yes, we can hear you.
Okay. Okay, let me put the full screen. Okay. Hello, I am very grateful to be invited to the Indian Orthopedic Society meeting. It is a pleasure for me. I work in the military hospital in Lima, Peru, and also in the San Bernardo Clinic. As all of us know, the modern era of the hip arthroplasty begins with Surgeon Charlie in England, and he developed a different way to see the arthroplasty. That's why the Lancet said that it was the most successful surgery in the 20th century. But we have every day more total hip replacements. That means that the costs are increasing and the complications are every day worse. And this is because almost 70% of the orthopedic surgeons that do hip and knee surgery, they do less than 50 surgeries per year. So they are not like they don't have the training to do that kind of surgery as well as a person that do more than 50 surgeries or arthroplasties per year. Medicare is almost broken because of the cost that it means. So now we're going to talk about hip arthroplasty complications and the different solutions that we have. All of these complications are my own patients, I guess except one. This is a woman, she has a 67 years old, and she has an arthrosis of the right hip, excuse me, and also with a pelvis of Ortho, with a protrusion acetabulum. So we began to, excuse me, we made the surgery, and the resident told me he wants to dislocate the hip. Said, "This doctor, can I dislocate the hip?" Yes, okay, do it. So we tried to dislocate it, and we got a problem. I mean, normally this kind of surgeries with this image, you should cut the neck first and then take out the head. But in the operating room, it seems like it was easy to take it away. So the resident tried to take it away, and we heard a crack. We put the prosthesis, everything was good, and the day after the surgery, we take an X-ray of the knee because the patient has a pain in the knee, and she got that. We made a fracture of Hoffa in this patient, so we have to revisate the patient, and we do a synthesis of the fracture of Hoffa. So I think this is we should think about that, because if we have this kind of protrusion, we should first cut the neck and take out the head instead of trying to dislocate the head at the beginning. We also know about the Vancouver classifications, about a stable, which one are loose, and the C classification, there is no osseous stock. I got this patient, 96 years old. He has partial arthroplasty, and he has a B1 fracture. Even the B1 fracture is stable, and he has 96 years. We've made synthesis with plates and screws. It was not so difficult to do it because the prosthesis was stable. But it is said that in person that they have more than 90 years, even if the prosthesis is unstable, you can only do the synthesis of the fracture without taking away the prosthesis or changing the prosthesis, because it is a lot of morbidity for the patients. This is a type B2 fracture. The prosthesis was also stable. We did that. We only do circlage of the wire, and the patient was really good. It was like 20 years ago. Probably we won't do this again in this time. Another type B2 distal fixation we tried to do in this case. It was more modern. It was like 5 years ago. So we do, in this case, it was a B2 fracture with a distal fixation stem. We do that. We take and we do full porous coat arthroplasty, and the patient was going very good. We also did that in this case, another B2 fracture. We do a modern technology with a modular hip replacement. So we see that how it is changing. The time passes, and it's changed the different ways to treat different type B2 or B3 fractures. It's another B2 fracture. See this patient. He has a fracture here in the tip, in the stem. He has been operated before. This is his second operation. We do that here. We change the stem. We do put a long stem here. We do a peroneal graft, a synthesis of the fracture with a distal plate fixation. This is 2 years after the surgery. The patient was going really good. Can you see in the operating X-ray table? It's a long incision, but the patient moves the leg very well, and he's working very good. We can do that also in type B3 using a non-conventional prosthesis. See this fracture. This is a B3 fracture. We take all away, and we put a non-conventional prosthesis. Probably this is not the best way to treat it, but it's like a salvage operation. It's another type. It is a type C fracture with a stem that is well fixed, and we do it was like a regular fracture of the diaphysis of the femur, and we do synthesis of this fracture. Probably nowadays we won't do that. Maybe we can do it in a percutaneous way. This is not my case. This is a cortex of Dr. Miguel Cabanela. He was my professor in the Mayo Clinic. He has a patient with a hip arthroplasty and a knee arthroplasty, and he has broken here. He has a fracture here. And there was no good bone stock, so the only way to do here, to treat here with a total femoris prosthesis. I don't have the video of this patient that I saw him in the Mayo Clinic, but the patient is walking very good. That was the way to treat this patient with a total femoris prosthesis. We have also to take care about the cement and the screws, because when the cement, if you perforate the acetabulum, the cement can go inside the abdomen, and it will hurt or damage different parts of the body. Even with the screws, we have to take care with these screws. It is intra-abdominal, and it is very dangerous to put these screws in that way. And you see in this picture how the screws go very close to the external iliac artery. See where is the screw here? Number 6, close to the pelvic arteries and veins. Here, see the external iliac vein. So we have to be very careful with the screws in the position we have to take. This is another complication with an 88 woman. She has a fracture. We made a hip replacement here, and she got an arterial thrombosis. Finally, she finished with a supracondylar amputation of the left leg. So we have to take care about how can we treat in the post-operative this kind of patients. This is another patient, Mrs. Reyes Apesteguia. She was 66 years, wife of a colonel, partial right to the hospital, had a car accident. Those were the diagnosis, dislocation of fracture of the left acetabulum, left distal radial fracture, and left humeral fracture and radial nerve palsy. This is the X-ray of the hip. She got 40 days after the accident, and we were about the doubt to do a synthesis or to do an arthroplasty. Finally, we do that. We do an synthesis of the fracture of the acetabulum. It looks very good, but she was. We did it between 40 or 45 days after the accident. She was working with crutches without step, physical therapy for hip, wrist, and elbow, and the 6 weeks post-operative. And at the 6 weeks, she begins with pain in the right hip, pain in the thigh and right knee, left leg shortening 5 centimeters, and she cannot move the right hip very well. So we take an X-ray, and it happens. It broken again, and it dislocates. This is an X-ray. And you can see how the head it never go well. It has an avascular necrosis of the head, so that's why all the head goes away and dislocate again. So we do a hip revision, we did a Lavasant curettage and then a skeletal traction, getting ready probably for a total hip replacement. We got two problems in these patients. Problem one, we got a sciatic nerve palsy, and we got a deep bone infections. Finally, we do one debridement in 3 times. We put an spacer, and finally we do this. We put a total hip arthroplasty with cement with antibiotic, cemented in both sides, in the acetabulum and in the stem. The patient goes in this way. She was working very good. It is 5 weeks after the surgery. She stayed in the military hospital for 591 days, 1 year and 8 months. That was very expensive for the patient and for the hospital. The treatment was almost $103,000. That was very expensive. And I saw the patient once, and she said, doctor, thank you, because of you, I am walking. And I was very happy because the patient told me that. That was good for me, but she told me, it is because I had to sell my car to pay the hospital. Now I am walking. I don't have car anymore. This is another patient, a man, 50 years old. And we do, in this patient, he got an infected hip. We do an artisanal spacer. That's the way we do it. We put the spacer. He has not a good proximal bone stock of the femur. So finally, we put a tumoral arthroplasty, and that's the way finally it goes. The patient is working, and the prosthesis is very stable. It's another man, 75 years old. He has 20 years with the operation of a hip arthroplasty of the right leg, and he has a tumor in the right side. And finally, the diagnosis was between infection or metallosis. You can see here that the head is not in the center, so the polyethylene was the polyethylene was breaked, and we can see with the echography there was a tumor here. It was all metallosis. When we take away the acetabulum, we can see that the poly was all bad, and there was metallosis all around. Finally, we think we were a little concerned if it was infected or not. So we put a spacer first, and then we do a hip arthroplasty, a cemented hip arthroplasty with cement with antibiotic, and the patient is going very good. This is Sarah, 54 years old. She got a dislocation and a fracture dislocation of the hip. She has a posterior hip dislocation, posterior acetabulum fracture, femoral head fracture, 15-4. There was also, because of the inconvenience in the hospitals, got a delayed in the operation. We do a Bigelow maneuver for the reduction of the acetabulum dislocation. We take an X-ray and we see there was a fracture of the posterior acetabulum and a 15-4 fracture of the femoral head. So in this case, we were thinking about doing an arthroplasty at the beginning or doing a synthesis of the acetabulum and synthesis of the femoral head. Finally, we do the pre-operation, and in the operating room, the acetabulum was very little, and it was difficult to put a good plate. So we take a tubular plate, we bend it, and we put it like this. You can see here that the part of the acetabulum was really small, and we put this tubular plate to fix it. Probably maybe we should have done to put another plate here to support this, but we moved the patient and it was very stable, so we left it like this. That was the X-ray. Seems very good. But after 2 months, the patient began with sudden pain and functional limitation, and we can see that everything was dislocated, and that the implants have moved away. We did a reduction of the fracture. And we were thinking now to do an ORI for an arthroplasty. Finally, we decided to do an arthroplasty. We can see here that the femoral head fracture is never healed. It never healed. We take away those elements, and finally we do a non-cemented arthroplasty, and the patient recovered for the sciatic nerve palsy, and she's right now is doing very good, walking, and with no problems right now. This is Alan. He's 54 years old. He has a car accident when he was 20 years old. He has 3 surgeries. He has at the beginning a synthesis of the femoral head. He has necrosis, a vascular necrosis of the head. Finally, he has a revision in the States. After 15 years, he got another revision in Lima, and this was his revision. I saw him with these X-rays. Can you see? But the cap was absolutely loose. We take an aspiration, thinking about the infection. It was not infected. He is a patient. Also, is my friend. He's my neighbor. We took away the polyethylene. Can you see? It was very good. It was not loose. It was very good, but it never have contact with the femoral head. So we put allograft in the inside, and we use a cage. Even that the different doctor thinks that the cage is not a good indication in young people. This patient has been operated for me almost 15 years ago, and the case is doing very well, doing a little impaction grafting and cemented polyethylene. We put also a graft here in the proximal stem, and that's away 15 years post-operatively with a cap case that normally it is not indicated. Probably in nowadays we won't use this kind of indication, and we do a non-cemented or a tantalum cap, but this is the way it is working right now. This is the patient, and you can see the patient. This is a patient Nadal, 78 years old, with a fracture also. He has a delayed fracture. Finally, for doing it is faster. He has a complicated hip fracture, anterior and posterior fracture acetabulum. 3 weeks post-operatively, we were thinking about doing a synthesis or doing an arthroplasty. Finally, we did both. We made a synthesis of the acetabulum fracture, posterior and anterior, and we do a non-cemented hip arthroplasty. The patient is doing very good right now. So you can put if you have another people, probably you don't need to use a synthesis because it will have pain. So it is better to do an arthroplasty instead of doing another revision for another surgery. This is the patient. He's working very good. This is another case. She was a woman of 54 years old. We use a tantalum cap, and the patient has a dislocation at 4 months after the surgery. Can you see that the cap is anteverted? But at 4 months after the surgery, this cap is very, it is not loose. It is very, very well fixed. And it's very difficult to take out a tantalum cap because as you know, it fits very, very well. So what can we do right now? If we take out this tantalum cap, probably we can harm the bone stock. So what we do is we only take the polyethylene and we change the orientation of the cap of the polyethylene using a cemented polyethylene inside the tantalum cap. That was the only way. We reorientate the anteversion, and the patient 5 years post-operatively is doing very good. This is another case. He is a patient. He has 75 years old. He has a kidney tumor with metastasis in this bone. He has already been operated with this synthesis, but it didn't go well. So what to do? To do another synthesis, I think that it was with graft. I don't think it will be very good. So we decide to take away everything. We take away all the synthesis. We take away the head, the proximal femur, and take away. We got this, and we put a dual mobility cap with a tumoral prosthesis. And that was this is the post-operative X-rays, and the patient here.
Vamos. Giro. Vamos.
And this is the last patient. He is 81 years old. He has 4 hip surgeries, and the last one was done like 6 months ago. And in another hospital, they put purse because of infection of the last prosthesis he had. So he doesn't have a good bone stock, but the patient wants to walk. He wants to be operated. I tell him that there were a lot of difficulties for the operation, but he said, "Don't worry, I will take the chance." So we did. This is the proximal femur. Can you see that there is a lot of rods of cemented with antibiotic burns? We take away all the burns, and we put a dual mobility cap with a augmentation with tantalum in the acetabulum, and we do a modular arthroplasty. And that was the way it was working.
Yeah.
Extensión, extensión. Está bien. Ok, perfecto.
Yeah.
And that was the initial X-ray, and in the post-operative X-ray, we had the chance to put a prosthesis, tumoral replacement. But I think that with this modular stem, the patient can go better than with a tumoral stem. We got a dual mobility cap with a tantalum augmentation. So I think that exit of this infortunium with the patient is never leave the patient, to do a good informed consent, and you have to die with the patient and never leave the patient away. This is a Mayo meeting course in Peru that we do every 2 years. And in this time, Dr. Daniel Berry, Dr. Lewallen, Trussell Sierra, and Nicolas Bedar will be in Peru with different national professors and international professors. So all of you from India are invited to this meeting in Peru. Thank you very much.
Thank you very much, Dr. Marcelo. Anyone who is busy in practice is prone to see a lot of complications. Thank you for sharing the complications and how to manage them. Do we have any questions for Dr. Marcelo, Dr. Torres?
Dr. Lizárraga, what are your main considerations in your practice to discard infection when planning a hip revision surgery? How do you do?
Can you repeat your question because I don't understand you?
Your main considerations in your practice to prevent infection when you're planning a hip revision surgery?
Well, I think that you have to, if you want to avoid infections, you have to do different plans, no? First of all, you have to do an PCR and BSG to see that the patient is not infected. You have to do a aspiration of the hip. I think with those two things, you can decide if the patient is infected or not. You can with a blood test and with the aspiration. I think those are the initial ways to see if the patient is infected or not.
Thank you.
Okay, thank you very much, Dr. Marcelo. That was a very extensive presentation, and thank you for sharing your experiences. Now we have a talk on pre-operative planning in the upper limb using virtual low-cost tools by William Gibaha. Dr. William Gibaha is consultant orthopedic surgeon and specialist in hand and upper limb surgery in Lima, Peru. He has done fellowships in hand surgery in Spain, Colombia, and USA. Over to Dr. William Gibaha.
Okay, thank you so much for the invitation. Now I'm sharing my screen. Then we can see it. Okay, right?
Yes, clear.
Excellent. Okay, so in the next minutes, I'm going to talk about preparative planning in the upper limb when using virtual low-cost tools. I think this is an interesting topic that we have developed here in Rehabilitation Hospital, where I've done my residency and where I currently work, although right now I'm in Spain during my fellowship. So what are the objectives of this talk? We will recall the importance of surgical planning and templating, know about what current virtual methods for planning there are, to explain how we can create cost-free or low-cost tools for this templating, and represent all of these with applicable clinical cases. So as a brief introduction of planning, we know that there are softwares that will allow you to plan your surgery either for fractures, for replacement surgeries, and there are many papers validating these different types of planning systems. They are very useful, and I had the luck to use some of them when I was in external rotations. There are softwares available that are friendly, easy to use, and that will give great information for your surgical planning, especially on complex cases. But the problem of these are the costs. And we, being in Peru, our institutions, even though they are referral hospitals, they are not able to buy these softwares. So what can we do? We look for the guidelines of the AO when we have this traditional surgical planning, when we had to cut the x-rays or templates and do it by hand, trying to reproduce what we wanted to do in the surgery and translate that to paper when using these transparent films. That was very useful, especially when we had physical x-rays. But at the moment, the x-rays are not printed, they are in a DICOM system that we can only see in the computer. So these things that we did in the past, or even in the first years of my residency, were no longer an available option. So we wanted to move on, and we started creating these implants made in the computer and designed to have the similar applications to translate exactly what was on paper to the computer with the available tools that we have. We of course know that the operative planning includes many aspects, not only the implants, but also the maneuvers, the risks, the goal of treatment. We have more than one fracture or one problem to assess. We need to know where to start first. But this lecture will specifically enter on the implants because this is what we have decided, and I think it's been very useful. In the beginning, we started doing this with fractures. This is a distal radius fracture. The CT scans are always very important, especially in articular fractures, to help us on the planning, to know what implant to use, what approach to use. And based on this, we design our own templates. These are designed initially we used Paint as a very low-cost tools. Then we try to do it a bit more professionally with a CorelDRAW, which is also a low-cost program to be used in the computer. What can we do? What is the idea of this? We wanted to replicate exactly what we did on paper. So we removed all the bone fragments of the fracture. We reduce them. We give them the angles, the natural anatomic characteristics that we want to achieve. We translate these to the PowerPoint, so we can then add our implant already to the scale that we had of the X-ray. We can also do this in the lateral picture and add it to our presentation to have a simple preparative planning. Why is it low cost? Because we are just using paint to cut the pieces. We're using PowerPoint to rotate, to translate, or to add the template on our picture. This is a small video. In our hospital, we do a lot of hip fracture. I think that's one of the things in big hospitals. But this is the idea. We cut this picture in paint, and then we just reduce that just as if we were working on paper, but with these available tools. Then we designed the templates that we wanted to use, and we started to applicate these to more complex cases. So that's the thing of this presentation. So this is a shaft fracture of both ulna and radius. And what we can do here is reduce the fracture, demonstrate this, apply a plate according to the approach that we might be considering. This template is already scaled to the dimensions. You see this small white ball that is our frame to do the application and the sizing of the implants. And also we wanted to do a bit more, because every time we face something new, we look for more problems that we need to solve. So this is a Phyllis plate. Not only in our designs we use the implant, but also the directions of the screws, the height of the tip of the plate where we want to place that in. And in this proximal humeral fracture, what we can do is just using these similar tools to place our implant in the exact position that we want to achieve in the surgery, and especially in this E screw that we want to go as close to the calcar as possible, and see if the plate will be useful for us. Something that we've been seeing is some of the implants are not designed to Peruvian population, but I think that will require more studies. But this is a very good idea to approach and to do everything before our surgery. Then we can add the number of positioning of the screws and do this. Also, we wanted to improve the imaging of these implants. This is a black background, but if we translate it to a white background, we can also see we accomplish this by drawing a white and a black line with every implant. Very useful. And now I want to show you some complex cases where we can apply these. For instance, when we want to work for osteotomies for malunions, we know that there are deformities that it can be either angular, rotational, or translational. Even though they are three-dimensional, we don't have the tools that are available in maybe other places to plan the surgery. For instance, this is a 3D customized planning where they reproduce with the CT scan the reconstruction of the contralateral side. They invert the image, they merge those two images, they plan the cuts with this very sophisticated software. They can even design a specific customized implants for these complex cases. But it looks very beautiful and very useful, but these are not things that we have available in our country, and probably it will take so much time for us to achieve that. In our reality, what we do have is the concepts, the rules, and the types. For instance, this is a 2D image, and we can apply this to any other osteotomy that we want to plan. We figure the center lines, and we enter the cora, which is the center of rotation of angulation. This will give us a bisectrix, and this other point will be the ACA, which is the axis of correction of angulation. If we go work on this axis more laterally and trying to do an opening wedge osteotomy, we can align the defect. And if we do it more immediately in this case, we can do a closing wedge and reaching the similar outcomes. And we can do this only by using PowerPoint and Paint. So I think that's the wonder of this device. In other complex deformities where the cora is not matching the ACA and the tip of the deformity is further distally, we can say if we perform an osteotomy close to the ACA, our results will not be as expected. But if we do that closer to the tip of the deformity, we can correct that bone deformity. And I think this is very useful because we can try as many times we need this in our paper. Sometimes it can be hard, but the more that we do it, I think it's easier. We can get used to that, and our residents are pretty happy with this. This is a 16-year-old male patient with a malunion of the radius shaft. So We draw our lines. We measure the angle if it's 20 degrees of antecorbatum. Then we can measure how much wedge we want to remove for a closure wedge, and how many, in this case, 5 millimeters of anterior cortex would be enough to do a 20-degree closing wedge, and then we place our design implant, and our surgical planning is noted to that. These are the intraoperative images where we do exactly what we planned. We measure this in the OR, we do the closing wedge osteotomy, and our results are pretty similar of what we have planned. This is another case, a 15-year-old female patient. She had a previous history of elbow traumatism, and then she comes with this deformity. This is the plain X-rays, and when we measure this, we know that there is a deformity, acquital valgus, and we plan also doing a closing wedge osteotomy. These tools provide us the availability to measure the width and the height, and where to do this osteotomy, and to place the implant that we need to work on. We discussed this with the head treating physician or the attending, and we obtain also these pictures from the OR, reaching also what we have planned. We know that sometimes in osteotomy is trying to be perfect is not always the goal, but to be functional. The patient at the year follow-up achieved these expectations. This is another 15-year-old patient, also with a cubital valgus in this case, but here we find some abnormal malunion in the lateral column. The CT scan reproduction shows us this. The ectoscopic deformity is close to 35 degrees of valgus, but if we look for the X-ray, the valgus is a bit more, close to 43 degrees, and we want to correct that. We start planning maybe to correct first the malunion of the lateral column, and then to perform an osteotomy for the medial aspect to final the correction of the last 10 degrees. Here we have a functional physiological valgus of 10 degrees and the application of our implants. These are the intraoperative pictures trying to achieve what we have planned. Here we notice that we were not able to solve the lateral problem of the column, but the functional outcome was good enough, at least in our expectations. This last case is a 48-year-old male, high identity trauma, murdered by accident. These are the X-rays, segmentary ulnar fracture, and a complex distal radius. If we see the CT scan, the distal radius is completely destroyed, possibly not amendable for primary reduction. So what do we plan? Initially, we try to fix on the segmentary ulnar fracture, but we have considering that sometimes we not always have the proper implant. We need to see the length of the plate that we want to apply, and if we have that plate available in our institution. Otherwise, we might try to do a double plating. And here, since we are not able to reconstruct the distal radius, we want to fix the large bony fragments like the styloid or the volar teardrop, and use a spanning plate as always, or in our institution we don't have a spanning plate, so we use as a LCP plate, and we need to see if the longest LCP plate available in our institution will be useful for this. Otherwise, we need to change that to external fixation. So we plan this, and hopefully we can translate this to the reality. As we have seen, the plate was not long enough to solve the ulnar fracture, but it was long enough for the spanning plate, and the ulna had to be a double plate. So I think the take-home messages of this is to fail in planning is to plan in failing. I think this is an important thing. We need to address all our tools, what we have in our institutions and in our hands to improve our planning. We need to remember that in paper or in the computer, we can try as many options and make as many mistakes or redos, but not in the OR. So we need to work on this and have all the surgical team to be aware of our plan, what we have, and also adapt our plans to our realities. Thank you very much.
Thank you so much, Dr. William. It was a very interesting topic and something that can be very helpful for young surgeons in deformity correction and even in, I guess, in hip replacement. Thank you very much for your presentation. Do we have any questions? Dr. Lozano?
No questions. Good job, William, at your hospital with your new tools for the pre-operative planning. It's a great idea and very low cost.
William, just a question. It's a very interesting tool to planning a surgery, but can you give us an extra tip when you have a complex distal humerus fracture when you are planning?
Yes, for example, a complex distal humeral fracture would be those that are too distal that will require a specific approach. For instance, if you need to think of doing a olecranon osteotomy, so that can enter to your planning. Whether or not you're going to use a double plate that will be on 80 degrees configuration or it will be in an orthogonal configuration, you can use that on your templating based on how your fracture lines are being presented. Something that we have done also in the hospital for these complex cases is to do a plan A and a plan B, all with these tools, so we can know what to do when we're facing the surgery at that moment. So I think having a plan B or sometimes even a plan C is good than having no plan at all.
Thank you.
Okay, thank you very much, Dr. William. Now I invite Dr. Jose Castro Obiso to talk on subacromial balloon for irreparable rotator cuff tear. Dr. Obiso is upper limb surgeon at Alimanara Hospital and British American Hospital in Lima, Peru, and is also current director of SLAD in Peru. He is fellowship trained in hand and upper limb surgery in Peru, Spain, Paris, and USA. Over to Dr. Jose.
Okay, thank you. Can I share my screen?
Yeah,
Can you see?
We are able to see your screen. We are able to see your
Okay,
screen.
thank you. Okay, so first of all, let me thank the Indian Society for the invitation. I am Dr. Jose Castro, and today I'm going to talk about the subacromial balloon. In those places, I perform my clinical practice. So when we have a patient with irreparable rotator cuff tear in the functional shoulder, there are many options of the treatment. So we have conservative treatment, bicep tenotomy, and we have a subacromial balloon. This technique was introduced in 2012. It's a spacer that's made of polymer and is insufflated with normal saline. There are 3 sizes, large, medium, and small, and the spacer degrades over 12 months. So this technique has some benefits. So the first benefit is the biomechanic benefit. The balloon restores the glenohumeral contact pressure, allows the depression of the humeral head, increase the deltoid load, and for that reason, restore the concavity compression of the glenohumeral joint, allows the compensated functional shoulder motion with minimal pain. So how about the clinical outcome of this procedure? There are some papers published about that. This paper is published in 2018, and the follow-up of this procedure in this paper was 3 years, and they reported 46 shoulder, and the result was reduction of the pain scale in 3 points. The Oxford shoulder score from 21 to 44 points, and a high percentage of patients are satisfied postoperatively. There are another publication about this procedure. So they reported 26 patients, follow-up was 5 years, and the results show a statistically significant improvement in pain up to 5 years post-implantation. And the functional measured by the Oxford shoulder score and short form 12 score showed improvement up to 2 years post-implantation. In addition, there are some meta-analysis of these implants. This meta-analysis included 10 studies, 261 patients. And the conclusion of this meta-analysis was the technique achieves satisfactory outcomes when we talk about the constant score, ASIN, range of motion, pain, and another measures between 3 months and 3 years of follow-ups. Nevertheless, this is the systematic review published in 2021, and they concluded there is not a strong evidence available. So another benefit is maybe is there any cost effectiveness? So there are some publications about that. This paper was published by Alessandro Castagna in 2019, and they compared different technique of the irreparable rotator-cuff, such as subacromial balloon, partial repair, reverse shoulder arthroplasty, and conservative treatment. So they analyzed in terms of the cost per quality adjusted life years gained, and they and their conclusion was the subacromial balloon is more cost effective than the partial repair and reverse shoulder arthroplasty. The conservative treatment is the least costly management strategy, and maybe that subacromial balloon is safe and cost effective. Another advantage of this procedure we can use in a medically debilitated population. The procedure can also be done under local anesthesia with fluoroscopic or ultrasound. Consequently, we don't require any general anesthesia. Nevertheless, the main question of this procedure is who could it work on? It's really important to choose the ideal patient when we use this technique. Good outcomes are predicated on proper patients when we select the proper way. So what could be the ideal indication? Firstly, elderly patient, lower functional demand, active forward elevation over 90 degrees, teres minor intact, subscapular intact, and finally, they doesn't have osteoarthritis, or maybe they have minimal osteoarthritis. So I show you some cases about this technique. This is a 60-year-old patient, housekeeper. She had to fail arthroscopic rotator cuff repair. During the physical examination and MRI, we found subscapular and teres minor intact. And this is X-ray of the shoulder of this patient. We see minimal osteoarthritis. This is the active forward elevation over 90 degrees, and she had weakness and pain, as we can see in the video. So in this case, we proposed subacromial balloon. We started the standard arthroscopic. We don't see any rotator cuff. So after that, we performed the subacromial debridement, and this is the setup of the balloon. So we started to implant the balloon, and the cannula of the balloon entered in the shoulder, and we should see the black line, the proximal side of the cannula. As we can see in the video, this is the black line, and this line is relation to the graded tuberosity. Then the balloon was insufflated with 25 millimeters of the normal saline. And after that, this is the final result of the balloon. We created a new space between the acromial and the humeral head. This is the result. This is the follow-up at 1 month. She had full range of motion with minimal pain. And she recovered some strength of the shoulder. This is another case, a female, 69 years old, housekeeper, active forward elevation over 90 degrees. During the physical examination MRI, the subscapular and teres minor intact. This is the MRI of this patient. And we found minimal osteoarthritis. So we proposed the same technique, and this is the follow-up at 4 months. She had full range of motion with minimal pain. So to sum up, the subacromial balloon could have biomechanic benefits, could get good clinical outcomes, and could be cost effective. And maybe this implant could use in the medically debilitated patient. Nevertheless, the key of this implant is the selection of the proper patient. Further higher quality studies are needed to direct the best use of this implant. Thank you.
Thank you very much, Dr. Jose Castro, for demonstration of an important treatment technique in the shoulder, especially for an irreparable rotator cuff tear, where the options are quite few. Thank you very much. And now we have one additional contraindication for intraarticular injection, that is presence of a balloon inside. Okay, so now I would like to invite Dr. Christian Lozano to talk on arthroscopic treatment of stiff elbow, indications and limitations. Over to Dr. Lozano. Dr. Lozano is orthopedic surgeon at British American Hospital. He is also AO Trauma Upper Extremity Education Task Force personnel and a member of SICOT International Council, SICOT Educational Committee, and SICOT Trauma Subspecialty Committee. It's also in ISACOS Elbow, Wrist and Hand Committee and one of the board of directors for SLAD and SPOT. Thank you for accepting to talk for us, Dr. Lozano. Over to Dr. Lozano.
Hi, Sashi. Thank you for the invitation and thank you for inviting me to participate for this WIROC Global. I'm going to share my screen. Can you see it?
Yes, clear.
Okay, at this time, I'm going to talk about the arthroscopic treatment of stiff elbow. What are the indications and what are our limits? I don't have any potential conflict of interest. And as you know, the main function of the elbow is to position the hand in space to act as stabilizer for actions such as carrying, throwing, pushing, pulling, and lifting. So after this, you accomplish that each function of the elbow is to be or have the elbow full range of motion to put the hand wherever you want. So stiffness and contracture of the elbow result in loss of motion and difficult performing activity of the daily living. What are the, in elbow surgery, what are the general principles? You have to know that open surgery more prone on specific surgical complications like contracture, heterotopic bone, and infection. What are the elbow arthroscopy advantages? That you have less contracture or less heterotopic ossification concerns, low morbidity, less pain, early range of motion, decreased surgical injury to surrounding musculature, decreased recovery period, improve articular inspection, and improve cosmesis. The disadvantage or concerns for elbow arthroscopy at this time is that technically it's very demanding. You have to require some experience to perform an elbow arthroscopy by yourself. You usually have to be with another surgeon that have the same expertise or the same skills as you have to perform a good elbow arthroscopy. So it's as I told you, technically demanding at the beginning, but after you perform some of them, you can see that maybe elbow arthroscopy is very nice and maybe not as difficult as you can think that they are. But what are the pathophysiology of stiff elbow and contractures? The osteoarthritis is one of them, trauma and fracture, other one, surgery even if produces a stiff elbow, cerebral palsy, traumatic brain injuries, burns, too much immobilization, and some congenital condition like arthrodeposis or congenital radial head dislocation. In pathoanatomy, we have intrinsic causes, extrinsic, and mixed causes of a stiff elbow. For example, for intrinsic, joint incongruity, synovitis, loose bodies, intraarticular fracture, malunion, and osteochondritis dissecans and post-traumatic arthritis are the intrinsic causes of a stiff elbow. The extrinsic causes, formation of scar following a burn, heterotopic ossification, adhesion, contraction of the capsule, ligament contractures, scarring of posterior oblique portion of the medial ulnar collateral ligament, and we have mixed intrinsic and extrinsic causes of a stiff elbow, like late effect of intrinsic contracture can lead one goes to another. And the prognosis with the arthroscopic treatment is that patients are able to perform activities of daily living if the elbow range of motion of 30 degrees of extension and 130 degrees of flexion is achieved. Most activities in the daily living need 100 arc of motion at the elbow to be functional, but 30 degrees of loft extension is well tolerated by most of the patient. Flexion loss causes more dysfunction than extension, so you can lose usually when you have an elbow trauma or elbow condition that you make a surgery, maybe you will lose 5 to 10 degrees of extension, but when you lose the flexion, maybe as I told you, the flexion is the most important function of the elbow, because if you lose flexion, maybe you can touch your face, you can't brush your teeth, or maybe you will be very limited to do your daily activities. So the treatment for the stiff elbow is non-operative and operative. With non-operative, maybe too much physiotherapy, and operative, I will show you some things that I want you to see. So the non-operative treatment is some medication like non-steroid anti-inflammatory medication, physical therapy with active and passive range of motion exercises, that usually is the first line of treatment in the most of the cases. The contracture results in less than 40, but in contracture of less than 40 degrees. Static splinting is not a good option. Maybe some persons will, or many surgeons will think that static splinting will work, but it does not work very well, as you can see with the results and the publication of the static splinting. You need to move the elbow to get more range of motion usually. But the treatment that I will show you is operative treatment, and you have many options for this treatment. Capsular release or release of the posterior band of the MCL, osteophyte decision, distraction, or interpostionary arthroplasty, total elbow arthroplasty, or musculocutaneous neurotomy. But for the arthroscopic treatment, we have some guidelines that Felix Awa published a few years ago, and we have some limits for the expertise that we have as arthroscopic surgeons. And Felix Awa divide the limits in some stages, from 1 to 5. And the stage 1 is the beginning elbow arthroscopy. The stage 2, limited experience with elbow arthroscopy and experience arthroscopies with other joints. The stage 3, experience elbow arthroscopies. The 4, advanced elbow arthroscopy. And the stage 5 is an early gut. But what we have in each stage. Stage 1, beginning of the elbow arthroscopy, maybe you can do diagnosis, arthroscopy, before an open surgery. You go with the scope into the articular surface, see what you want to see, and then you perform the open surgery. The stage 2 is a limited experience with arthroscopy and experience arthrocopies with other joints. You can perform a good diagnostic arthroscopy, confirmation of instability before open repair, removal of loose bodies, spur debridement, excision of the posterolateral plica, and arthroscopic irrigation and debridement of contaminated joints. Stage 3 is an experienced elbow arthroscopy. You can do all the stage 2 plus open or closed arthroplasty, debridement for lateral epicondylitis, the arthritic elbow. Maybe you can perform synovectomy, excision, radial head excision, and some other procedures that we have in the elbow with an arthritic condition. Complete management of osteochondritis dissecans, maybe the fixation of some fractures, and olecranon bursa removal, and synovectomy for arthritis, rheumatoid arthritis, chronic inflammation arthritis, or other arthritis. Stage 4 is an advanced elbow arthroscopy. You can repair tendons, you can reconstruct some instabilities, you can perform the close reduction and internal fixation of displaced intraarticular fractures, repair the tragus tendon, and release the ulnar nerve. And stage 5, I think is very complicated to get this stage, is to perform an allograft posterolateral reconstruction, fascial interposition arthroplasty, medial ulnar collateral ligament repair or reconstruction, radial tunnel release, and distal biceps repair. As you can see here, it's a short video. You can do synovitis, and we are cleaning the articular surface of the elbow. As you can see, evaluate the anatomical structures that we can see with the scope, see the radial head, and you can do whatever you want in order to get a good result. So the rehabilitation is very important after any elbow surgery, open or closed. Remember that this surgery usually is performed under regional block anesthesia, and maybe you can control the pain after the procedure. Continuous passive motion through full range of motion. You can perform it with some external braces. It's very important to compress dressing to help with the swelling, and usually we can do very early therapy that active and passive range of motion. Not very frequent that we use extension splint, but in some cases we need to get or to maintain the first 2 days the extension of the elbow. In some cases, as I told you, we use a dynamic or a static progressive splinted, but it will depend on the condition. The outcome of the arthroscopic treatment is improvement in range of motion can be variable. Most patients will retain 2/3 of the motion gain at the time of surgical release. You will not have the 100% after immediately surgery. You will lose some range of motion in the next weeks, usually. And as you can see, the result of the arthroscopic treatment of the stiff elbow is very convenient, because you can see that we can get more range of motion than open surgery, and the publications confirm that. And in summary, we can say that arthroscopic treatment of the stiff elbow is very safe and effective when it's performed by surgeon with appropriate level and surgical skill. If you compare with open techniques at treatment of Such treatment allows for a better visualization and treatment of interarticular causes of the contracture, and the complication rates between the two techniques seem to be comparable. However, permanent neurological complications have been reported more frequently with the arthroscopic technique, but you can draw your anatomic points of in the skin before you perform the arthroscopic surgery, and maybe you can see the ulnar nerve, and you can protect this nerve, because maybe is the most important part of this surgery, to protect the ulnar nerve. That is what I have to show you this day, and thank you, Sassy, again for the invitation.
Thank you so much, Dr. Lozano. That's a very interesting talk, and it's never late to learn another skill. Learning elbow arthroscopy can definitely open up a lot of horizons, make easy access to the elbow joint to perform a lot of procedures with minimal access and minimal damage to the soft tissues. That was very interesting. Thank you very much. I just have a couple of questions. What is the most common position that you use for elbow arthroscopy?
Prone. I usually use a prone position to perform the elbow arthroscopy. It's very easy for us. Dr. Castro, that is with us in this Zoom meeting, perform the same way. We usually work together in this type of procedure.
Okay, and what is the size of the scope that you use?
4 millimeters, the conventional scope.
Okay.
4 millimeters and 30 degrees.
Okay, 30 degrees, and that's 2.5.
4 millimeters.
4 only. Okay, so good enough for most of the elbows.
Yes.
Okay, so thank you very much, Dr. Lozano. So we move on to arthroscopic dorsal capsular ligament repair for scapholunate ligament lesion, talked by Dr. Jose Castro. Dr. Jose Castro.
Okay, thank you. I will share my screen. Can you see, Sasi?
Yes, yeah.
Great. So I'm going to talk about the arthroscopic dorsal capsular ligamentous repair in scapholunate instability. Okay, so like introduction, in recent years, management of the scapholunate injuries has been at the forefront of debates. Advances in wrist arthroscopic technique have redefined major anatomical findings and operative approaches. For that reason, there is better anatomical comprehension, and today we talk about the scapholunate complex. The scapholunate ligament complex has three elements. The first element is the intrinsic portion of the scapholunate, and it has three segments: the dorsal, volar, and proximal segment. The dorsal segment is biomechanically the most important. The second element is the main extrinsic ligament, such as the radioscaphocapital ligament, long radiolunate and short lunate ligaments, and the dorsal radiocarpal and dorsal intercarpal ligaments. The third element of this complex is the dorsal capsular scapholunate septum. This structure joins the dorsal capsule with the dorsal portion of the scapholunate, as we can see in this image, and we can see in the cadaveric specimen. These three structures are closely interlinked and appear to be the key of the scapholunate stability. For that reason, in 2011, Dr. Christophe Matula proposed this new technique. And the main goal of this technique is repair of the DCSS, or the dorsal scapholunate septum. And in this technique, they use the PDS suture, needle number 21, and consists in the first step, you first suture pass through the dorsal capsule and then through the dorsal scapholunate ligament tear in the lunate side, and this suture pass from the radiocarpal joint to midcarpal joint. The second step is the same way like the step one, but in the scaphoid side. The main advantage of this procedure is you preserve the dorsal capsule, and the muscle and tendon response to trauma in the dorsal and volar surface of the scapholunate exert a protective effect against the scapholunate dissociation. For that reason, it is very important to protect the dorsal capsule. Finally, we perform the knots. The first knot has been tied between the distal sutures, as we can see in this image, and then the first knot enter in the midcarpal space. Then the second knot tied between the two proximal ends and introduced in the 3-4 point incision. The reported 36 patients, and the mean delay from trauma to surgery was 90.8 months. The DASH score was from 34 to 90.5. All the patients returned to work an average time of 9 weeks, and the 7 professional athletes continued practicing at the same level as before the injury. Only 6 patients had occasionally slightly pain. This is the EWAS classification, and my presentation focuses in EWAS 3, A, B, and C. So I show you some cases about this technique. This is the first case. Male, 30 years old, suffered a wrist trauma. He had a pain in the dorsal of the wrist. During the clinical examination, we found Watson sign positive. He performed physical therapy for 2 months. However, the pain continues. This is the MRI of this patient. We can see the partial scapholunate tear, and we propose this arthroscopic dorsal repair. Firstly, we evaluated the scapholunate ligament, and in this patient, the proof entered between the scapholunate ligament in the dorsal segments. For that reason, we classify this patient in EWAS 3A. After that, we started to perform the arthroscopic dorsal repair. We pass the sutures through the dorsal capsule and then through the dorsal portion of the scapholunate, as we can see in the video. We use only PDS sutures and needle number 21. And after that, we retrieve the sutures in the midcarpal space. And we perform the knots. The first knot is tied between the distal ends of the sutures, as we can see in the video. This is the first knot, and the first knot enter in the midcarpal space. So this is the first knot, enter in the midcarpal space. And we can see the knot in the midcarpal space. So after that, we perform the second knot between the proximal ends of the sutures. And finally, the patient was immobilized with a short cast for 6 weeks, and after that, he started the physical therapy. This is the follow-up of the patient at 3 months. She had full range of motion without pain. This is the video of the patient. And he returned to work as before the injury. So this is another case, a female, 50 years old. She performed a manual work, had pain in the dorsal of the wrist for 9 months. In the clinical examination, we found Watson sign, and she performed physical therapy for 3 months. Nevertheless, the pain continues. So I propose in this case the same technique. First of all, we evaluated the scapholunate ligament. As we can see, the proof entered between the scapholunate ligaments, but in the dorsal side, so we classify this patient in EWAS 3A. We perform the same repair, and this is the final follow-up at 4 months. She had full range of motion. She didn't have any pain, and she returned to work. So there are some paper about this technique. In 2018, they reported 15 patients, and the mean follow-up period was 20 months. The scapholunate stability was classified in EWAS 3. Activity pain decreased from 7.8 preoperatively to 4.4 postoperatively. The final follow-up range of motion, inflection, extension, and the grip strength were estimated are 87 and 91% compared with contralateral side. Our experience, we have 4 patients. All of them return to work. All of them have full range of motion, and the DASH score was lower. To sum up, the scapholunate ligament, the extrinsic ligaments, mainly the dorsal intercarpal ligaments, and DCSS are the key of the stability in the scapholunate interval. The WIROC arthroscopic allows precise diagnostics and treatment at the same time. The arthroscopic techniques are the least innovative surgical techniques for scapholunate ligaments. For that reason, we preserve proprioception on the dorsal side, and this playing an important role in the stabilizing the scapholunate space. Thank you.
Thank you, Dr. Castro. It was a very interesting presentation. We have a question from Dr. William Gibaja. Dr. William?
Yes. Dr. Castro, I think that was an excellent presentation. I was just wondering, in the follow-up of these patients, if you notice that there is a new gap in the scapholunate joint, do you consider that as a problem or as a finding, or how can you assess this when you visualize this radiologically in the future?
Well, to be honest, I performed this procedure only in partial tears. So we don't see a gap in this patient, or maybe we can see gap during the functional X-ray. But I don't have experience in complete tears, because in my hands, when I have this type of patient, I prefer to do the open surgery.
Okay, good.
Jose, I would like to ask you a question. Do you use anchors in this kind of procedure? When do you recommend anchors?
Sure. I use anchors when the tear of the scapholunate is complete, and this type of cases, I prefer to perform open surgery, as I said before. However, in the original paper of the Dr. Christophe Matulai, they proposed to use just PDS suture in all cases, in partial and complete tears, by arthroscopic technique, but I don't have experience in this procedure.
Thank you.
Thank you so much, Dr. Castro. Now we will invite Dr. William Baha to speak on snap wrist management. Dr. William.
Okay. Okay, I'm sharing my screen now. Okay, I have a screen, right?
Yes. You're clear.
Okay. So, well, thanks again for this invitation. Now, for this part, I want to sum up the management for snack wrist. Snack wrist is a condition that is not a frequent condition. So, I want to give some reviews on the concept on the scaphoid injuries to understand its complications and how can a scaphoid fracture lead to a snack wrist. So, we will understand this through the physiopathology, also to understand the classification and the planning of the treatment. Finally, we will compare some alternatives. As an introduction, we have a 45-year-old female patient that comes with wrist pain, or in the past 2 years she felt some loss of grip strength, but she doesn't report any specific personal history of trauma. And we will note that this history is pretty common in these sort of patients. In our office, we can ask this patient to see on an X-ray, and this is what we find. This is an abnormal picture, and we're dealing here with a snack wrist. So we need to ask some additional questions, learn how it was developed, and why do these patients come so late at the office? So how does this happen? So a few words on the scaphoid. We know that this is like a peanut-shaped bone in the wrist with three main portions being the distal, the waist, and the proximal pole, which is particularly the troublesome pole due to its irrigation, which is quite popular on scaphoid anatomy. The scaphoid is irrigated from the dorsal carpal branches that comes from the radial artery. This gives over an 80% of nutrition to the scaphoid, and the lacking 20% is given by some volar branches. But in this, in any case, the proximal pole doesn't get enough irrigation, so it is susceptible to non-union or other complications. When there is a fracture on the scaphoid, it can be repaired, but sometimes it is misdiagnosed, it is mixed, or the problem occurred in the proximal pole, or it was well diagnosed but mistreated, or it was treated okay, but anyway it turned into a non-union for its poor irrigation. If there is also any condition like tabacism or any vascular condition, it may also lead to failure, so the scaphoid doesn't heal properly, and it leads to an scaphoid non-union. So when this happened, this is a patient after 21 months of operation with a percutaneous screw, but we see that there is still the fracture line and the patient did not recover well. In the CT scan, we can see some sclerotic borders, and when we're dealing with scaphoid non-unions, meaning no arthritic changes because that would be prior snack, then you need to solve that either with a non-vascularized bone graft or with vascularized bone grafts that can be either local, like the Seidenberg or the Soterianus techniques when they use local arteries, or even free grafts like the medial ephemeral condyle. Of course, this would require a more experienced microsurgery technique. But if arthritic changes occur, and that is the reason of this lecture, we're going for SNAC. SNAC stands for Scaphoid Non-Union Advanced Collapse. Usually, this is the term of evolution after 5 to 10 years after non-union has occurred. The problem with some scaphoid fractures and some non-unions is that they can be asymptomatic or cause just minor symptoms to the patient. So we need to look for previous history of wrist trauma. It can be well tolerated for a long, prolonged time. That will lead to delayed diagnosis. And usually when the patient starts to complain for pain, it's when some arthritic changes have already occurred. It's also frequent that a patient falls with an outstretched hand and complains of wrist pain, but when we see the x-ray, we know that this injury did not happen from this fall, but it happened many years ago. So we need to complete this evaluation with CT scans, MRI, or if possible, arthroscopy. There are other forms of advanced collapse, including the scapholunate, the malunion, and some that have been added recently, including Kienbock's and scaphotrapezoid osteoarthritis. Most of them have a similar physiopathology that consists on this. If we talk about the normal anatomy between the lunate and the scaphoid, they make an angle from 30 to 60 degrees. The scaphoid is the link between the proximal and distal rows, and biomechanically it's what it connects to both of them. It is provided with some stability for the intrinsic ligaments, especially the dorsal scaphoid ligament, which is stronger, and the lunar trochanterian volarly. But what happens when there is a scaphoid fracture and the scaphoid node union? Then this angle is lost. The distal portion goes to flexion, the proximal pole goes to extension, and the lunate goes to extension as well. So this linking row has been missed, and this makes the distal row to collapse in the carpal, giving these arthritic changes. So this non-union, these arthritic changes will start on the radial styloid. Then it can move to the scaphoid fossa, and in this evolution, then it can affect the capitate, initially in the scaphocapitate space, and then in the lunocapitate space, and finally it can lead to diffuse carpal osteoarthritis. There are classifications, but if we look in the literature about Watson and Bender that classified this was in the mid-1980s, so they were based on plain X-rays, and there are some minor differences, especially on the stage 2, which Bender considers the scaphocapitate, while Watson only the proximal radius scaphoid. But these are, to the date, there are, I believe, no proper classifications for this, and there are papers that have tried to prove the reliability of these classifications, and well, the conclusion of this is that X-rays are not enough to classify or plan this problem. If we add the MRI for cartilage injury, MRI itself just has a low sensitivity rate. But if we compare this to the arthroscopy, they not always correlate. Arthroscopy is a more important role to evaluate the chondral injuries, and it might be the gold standard, although it doesn't lack morbidity. So it's a tool that you need to know when and how to use it. So according to the staging, if there is a SNAC 1, you can either observate, you can do denervation, that's an option of the posterior interosseous nerve, or do only a radial styloidectomy. Also, if there is only a radial styloid osteoarthritis, you can you can perform a treatment for an scaphoid non-union and still get a good outcome. But in the stage 2, when there is already arthritic changes around the scaphoid, then your options are wider. But the most important thing, and we'll discuss this a bit later, is the Prosynorocarpectomy and the four-corner fusion. The main indication between them is if there is a compromise in the lunocapitate joint. But when there is compromise in the lunocapitate joint, then a proximal row carpectomy will no longer be an option, and then you may lead for a four-corner fusion. Now, sometimes mentioned in stage 4 or a panarthritis. In that case, total wrist function fusion will be the option when there is a compromise of the proximal row and the radiocarpal joint. So back to our initial case, this is the patient that I was introducing to you in the beginning of this lecture. And if we see the CT scans, then we find some periscaphoid abnormalities. We can classify these as stage 2, and based on the patient's demands, we plan for four-corner fusion. This includes resection of the scaphoid. It can be or without the innervation. Styloidectomy might be an option to diminish that impingement, and when we fuse this, we apply this bone graft, and we choose our method of fixation. It can either be this circular plate. Plates sometimes can be troublesome, especially when they try to extend. So there are some tips to prevent a posterior impingement, like doing a bit of a flexion of the scaphoid, of the lunate. Sorry. Other options are screws, which are sometimes a main surgeon's preference. You can use staples, or we can use K-wires if sometimes that's what we have available in the hospital. It can be done by the dorsal approach, that can be ligament sparing or nerve sparing. This is how the X-ray will look in the post-operative time and the long follow-up. We know that there are some sclerotic changes around the wrist, but the functional symptoms are still doing fine. The deformity correction is the most important step when doing this four-corner fusion. For this, the lunate that is in extension needs to be reduced to flexion, and the screw can be applied either directly or through the dorsal aspect of the distal radius. Or if you don't want to violate the proximal lunate, you can enter distally from the third metacarpal. It can be done in a single column, in a double column, as explained here, with either 1 or 2 screws. And it can also be done with the wrist arthroscopy, but the learning curve to do a full arthrodesis with a scope is, I think it's quite large. But the diagnosis it's not that much, and that can be a powerful tool. Of course, if you will do an open or arthroscopic fusion of the wrist, it will give you the same advantages of any arthroscopic procedures, even though they are explained in the future, they are quite similar, but the advantages of a less invasive procedure are quite clear. And what can we say about Prosynorocarpectomy? So this is not a discussion of which procedure is better, but which patient is needed for this procedure. The main indication for proximal row carpectomy is that the proximal capitate is intact, so it will make contact in the lunate fossa in the radius to have this function. If we make a comparison between these two methods in a stage 2, having an homogeneous group, we can say that proximal row carpectomy can have a better range of motion, but the four-corner fusion will give a better grip strength. So you need to choose a patient. If you are dealing with a younger patient, that possibly a four-corner fusion is the best option. And if you're dealing with an older or less demanding patients, then you can look for a proximal row carpectomy. Satisfaction rates are similar in both of these. This is another study comparing these two procedures, most of them being retrospective, of course, and having similar outcomes. But what we can say is that even in those cases, both are improved. There is reported more complications for four-corner fusions, but this is quite obvious. If you're using screws, plates, or any material, of course, you will have more rates of revisions or hardware problems than if you're using non. So I think this is not a thing to consider, but the patient selection, as I was saying, of what you want to expect to your patient to achieve, either in motion or in strength, because with either one of these treatments, you will sacrifice one of these. So the take-home mention is it's always important to prevent scaphoid complications. So if you are dealing with a scaphoid fracture or a non-union, you need to have a good follow-up so you can act when it's more proper. We know that carpal collapse is a sequence of biomechanical changes that lead to osteoarthritis. You need to get as much information as possible for your surgical planning and consider diagnostic wrist arthroscopy, especially if you want to do a proximal row carpectomy. If you enter with a scope and you evaluate the proximal capitate and you see that it is not injured, then you can continue with your proximal row carpectomy. But you find arthritic changes here, then that no longer will be an option and you will need to do a four-corner fusion. So patient selection is the most important thing. Thank you again for this invitation, and this is our hospital. Thank you.
Thank you so much, Dr. Gibaha, for your crystal clear presentation. Dr. Jose has some questions for you. Dr. Jose.
The wonderful lectures, Dr. Gibaha. I have some question. In your clinical practice, when you have a young patient with SNAC type 2, for example, how much influence does the patient perform heavy manual work in your decision between four-corner fusion or proximal row carpectomy?
Well, if we have ruled out any other possibilities and we need to choose between these two alternatives, if we're having a young patient that requires more grip strength, then I think the four-corner fusion will be a better option, even if the range of motion will be severely compromised. So we need to be in the same line with the patient. They need to understand that the range of motion will be diminished possibly to a half, but they might still continue working, which is what they need. That would not happen, of course, if we're dealing with an older patient with other demands. So I think that would be the decision-making process.
Okay, thank you. Maybe this is not the. This is another topic, but it's really important because there are some connection with the SNAC lesion. What is your opinion about the arthroscopic graft in scaphoid no union? Because the learning curve of these techniques is longer. So do you believe it's worth developing this technique?
Well, I think if you have the chance to do for instance, if you're a referral center or a referral hand center and you will work with many scaphoid non-unions, then possibly it is worth to start on this large learning curve for arthroscopy for non-unions. But if you're doing maybe one or two a year, if you're not doing too much, or if you don't have that possibility, then it might not be worth, because it will take too much time. And finally, if you compare the two alternatives, they are quite similar. So I think that depends on the chances that you may have.
Thank you so much.
Thank you so much, Dr. Gibaha. over to Dr. Marcelo for his talk on proximal femoral fractures, tips and tricks for success. Dr. Marcelo.
Can you hear me?
Yes.
Yes,
Okay.
it's clear.
Hello.
Yes.
This is. Okay, this is my last talk. Thanks again for the invitation. I'm going to talk about proximal femoral fractures and tips and tricks for success. As all we know about older people with this kind of fracture have different comorbidities like we're seeing here. We're not going to talk about that because it's only 10 minutes talk. Most hip fracture surgery goes very well. So why we should talk about this? Because even if most of them go very well, we can still improve. There is a failure of the oris in about almost 40% in unstable fractures. Not in stable, but in unstable fractures, there is almost 40% of problems. And when it happens, when there is a failure, the failure is very costly because it means to reoperate and maybe to change the devices or to make a prosthesis. And the cost is cost for the patient, it's cost for the family, it's cost for the society, and also cost for the insurance. Rule number one, you should know the fracture type. You should know which one is stable, which is unstable. You should not confuse because between pears with apples. So in the 3-1-A1 to 3-1-A2, those are stable fractures. The unstable are the 3-1-2 to 3-1-A3. So those are unstable. So for a stable fracture, you can use plates, but for an unstable fracture, you must use nails. You should know about the structural controlling forces, what happened with the proximal fragment that goes in abduction and flexion, and what happened with the distal fragment that goes in adduction because of the adductor muscle groups, and the other one because of the gluteus medius, and the iliopsoas. Rule number two, you should never leave this fracture in varus because it won't go very well. So this happened with this kind of fracture. If you leave this fracture in varus, it is probably that the implant will break, or we have another refracture or the pseudoarthrosis of this fracture, or because of this varus pain in the hip. And the principal way to avoid the varus is that you should put the shunt pin medial to the tip of the gradient trochanter. If you put it a little laterally, it will go in varus. So there are different works about that you should do. If you do a lateral starting point, it's similar to put this fracture in varus. So it must be just medial to the tip. And how to deliver a starting point like in this kind of fracture, you should pair it with a shunt pin using like a joystick. Here using a joystick, so you put it in a real AP view, and you can put a pin exactly medial to the greater trochanter, and that's the way to go. This is the final follow-up. Rule number 3: respect the lateral wall. What is the lateral wall? It's part of the pertrochanteric fracture. It's not a separate anatomical structure in a normal femur. Why the lateral wall is important? Because provides a buttress for the proximal fragments, allows controlled fracture impaction. Without it, you convert to a reverse obliquely equivalent. This leads to uncontrolled collapse. What does mean? Like this here. You have a good lateral wall, and these proximal fragments won't displace. But you have a breaking lateral wall. When you do this kind of implant, it will displace. Big hole plus non-collinear rimming is similar to lateral trochanteric wall fracture. That happens frequently, often because, why? Because this lateral wall is very thin, and you want to put like a dynamic hip screw like here. This almost 17 millimeters in the proximal part of this device. It happened to me. It happened to me. It happened to you. That you break this lateral wall, and also it is not. It is a 4-part fragment, so it is you convert it from a stable fracture to an unstable fracture. And if you put this device, probably it won't go well. So if there is no lateral wall, there should be no hip screw. Little holes plus collinear rimming means intact lateral trochanteric wall. So if you do little holes with this kind of plateless percutaneous compression plates, there won't be lateral wall fractures. Almost 2% compared with a sliding hip screw that is almost 30%. We don't have this kind of device in Peru, but I think it's a good way to work with if you want to use this kind of plate instead of a sliding hip screw. Number 4, reverse oblique fractures, always nail it. This is an established incidence of 5% of oblique intertectonic fractures, and the recommended fixed angle device is nail. It is expensive, but for the future, it won't be so expensive because it will be costly if you use a dynamic hip screw. This happened with a dynamic hip screw. If you put in an oblique fracture, it will displace. And those are different treatments for reverse obliquity intertrochanteric fractures. And how does it fail? If you put an DHS, almost 56% of this fracture fails. With a nail, long nail, 30%, with a DCS, 30%. And look at that, with a simple angle blade plate, 95 angle blade plate, 13%. If a nail, proximal femoral nail, is well put, it's almost 0%. So you should know the unstable intertectonic fracture patterns and nail them. Number 5, pick the right table position. There are different ways to do this, depends on what you have in your hospital. Lateral is beneficial with subtrochanteric fractures. Lateral is beneficial in the morbidity obese. This is the way we do with a C-arm. This is one of the positions for the C-arm. If you have all the conditions, this is the way we do it in the clinic with a C-arm, with the leg abducted and flexed. We can see in frontal and lateral in a good way. And in other hospitals we don't have a traction table, but we use the resident, the strongest one. He will be the traction table. Don't forget to put this device in the proximal part of the femur, so it will elevate it. Otherwise, you're going to see that there is not a real anteversion, and you're going to be a sac, and you want to be in the lateral position with a good anteversion of this proximal part. In obese patients, it's better to do it laterally. Number 6, opening is not a sign of weakness. You're not supposed to do a biologic insult, but you can do open reductions directly or indirectly with mini invasion procedures. Opening doesn't mean that you have to commit a first-degree murder of the bone. You should gentle handling. You should place clamps without anti-strapping. Infernal fixation is not a good way to do it in this moment. There's a woman of 75 years old. You see that there is a fracture. We tried to reduce it with a traction table. It didn't go well. It was displaced. She made a little incision, we put a clamp, and then we fix it with a proximal femoral nail, and that was a good one. We put a wire here, and the fracture was very good. Rule number 7: the tip apex distance matters. You know what is the tip apex index? Almost in the frontal and the lateral position. Normally it's less than 25 millimeters. If it's better, if it is less than 20. It was talked by Baumgartner et al. In insert for nail or plate. The tip apex distance is for sliding screw and for nails. In the past, the professors taught us that the device must be low and posterior in the neck. Now we should avoid it because it increases the tip apex. It should be deep and in the center, 10 millimeters of subchondral bone. This is the way, exactly way, what it should be the nail or the DHS. Rule number 8: don't use locking plates. This is the injury. See the fracture. It was fixed with a plate, proximal plate, not the percutaneous one, and see that the fracture is very well reduced. The final follow-up, the fracture has consolidated, looks great, but in clinical series, you can see that this kind of devices can break, can go the fracture in varus, and 30% of these plates require more surgery because of failed fixation, for malunion or malalignment, or because of deep infections. And there are some risks for failure, like comorbidities, medial instability, fixing varus, or manufacturing plates. Number 9: avoid nail destruction. Do not traction so much, otherwise you're going to displace the fracture and the nail can break. Number 10: beware with anterior cortex of ephemeral diaphysis. In older people, the femur enlarge and bow. If you use curved nails, it's better to use curved nail than straight ones. Because the straight one can put pinch and perforate, and the distal screw works like stress razors and it can fracture. Never use hammers, and you have to beware with a iatrogenic fracture. Rule number 11: reduce the fracture, then rim. When you prepare the canal, if you don't reduce the fracture and you put the nail in this way, obviously the fracture is displaced. Probably it will heal, but this patient must have probably pain because the proximal part of the femur must be anatomically reduced. So you should, before putting the plate, you should reduce the fracture and then you can nail it. Rule number 12: try to reduce with positive medial support. What that means? There is an article about that. The positive medial support means that the proximal part of the internal cortex of the proximal part must be ahead of the distal part. This is the positive one. When it is anatomic, they're in the same level, and when it's negative, it is before the distal part. This is the negative one. You can see it. It is behind. So in this kind of position, the slide can display it. If you're in a positive one, that means almost in valgus one, in the valgus position. When it displays, it can touch here and it won't displace. Those are different types of fixation: in the negative one, in the neutral one, and in the positive one. Rule number 13: do not forget the external fixator. I don't know if in your countries you use this kind of device for fixation of the intertrochanteric fracture, but in our country we use it in some places because number one is very cheap. It costs $150 compared for about $2,000 for the proximal femoral nails. We can do it in the percutaneous way. It is very easy to do it. It doesn't bleed. So you should never forget, because it's a way when in undeveloped countries for people that they can afford a nail. Number 4, if all else fails, use a nail to connect head to the shaft and lock distally. Like in this case, a gunshot, we use this nail, proximal femoral. It seems like it was working. 6 months, the lag change. See that it breaks. We change the nail to the PFN. It didn't work. Finally, we use a modular hip arthroplasty. Number 5, rule number 15, use threaded pins, not the smooth ones, because smooth ones can displace in that manner. This is not mine, but I found it. So you should take about this. The patient didn't die, but he cannot move so much, I guess. Rule number 16, never use hammer. This happened to me. See, this oblique fracture, we put a nail and I hammer it and I break it. I break it here. So finally we reduce it with a plate, but you should never hammer it. Number 17, not always the last is the best. See, in this case, we use a plate like this. It didn't work, it is costly. And if you use a regular plate, an angle blade plate, 95 plate, it will heal better maybe with another plate. So this is my last talk, and I have to thank to the Indian Society for the invitation, and I hope you can be in Peru someday. We got that meeting in Peru in this year. I am sure that Dr. Torres has invited you to this meeting, and we really are a pleasure to be with you here in Peru. Thank you very much.
Thank you so much, Dr. Maslow. That concludes the program, and we have involved most of orthopedics. That includes trauma, arthroscopy, arthroplasty, and the program was very interesting. Thank you so much for making this happen, Dr. Lozano, Dr. Torres, Dr. Marcelo, Dr. William, and Dr. Jose Castro. It was a wonderful program. Thank you for accepting to talk for us. Thank you.
It's been a pleasure.